Speaker is Ning STRUBE from Canada.
Thank you for the invitation. Let's see if I can figure this out. I don't know how to do this. So I'm speaking on 3 pretty simple procedures, strabismus. The first one will be just my approach to plication. Let's see. Nope. Well, it's in a different order. Can you help me?
Sure.
I don't know what's going on. It's going
Yeah,
back
it's
and
playing.
It's playing now.
Okay, we'll start with the central plication. It's a little out of order. So it's going to go fast because I only have 3 minutes. This is a procedure. It's a mini plication to correct 5 to 6 prism diopters if it's vertical. Here we're just isolating the muscle using a suture as a traction suture. And then you'll suture the posterior 1/3 of the muscle. This is a 6-0 vicryl suture that I'm using here. And then you make a single throw, a second throw for your knot, and really simply just attaching the 2 ends to bring that central part of the muscle anteriorly. For horizontal deviations, we found you get a little more of an effect, about 6 to 8 prism diopters, so you can do it on 2 muscles if you're trying to correct a small deviation, 12, 14, 15 prism diopters. More and more we're using Mercilin non-absorbable sutures, so I'm just showing here what your Morad has shown and others, putting the sutures posteriorly so they don't erode the conjunctiva. So that was the central plication. Let's see what's next. Okay, the central tenotomy, 1 to 2 prism diopters max. It's a really quick procedure here. You're cutting through conjunctiva and muscle. There's no suturing, there's no glue. It's not for horizontal deviation. So this is if you have a little residual vertical that you're trying to correct. Patients who've had refractive surgery, this is a nice little procedure you can do in your surgical suite. And then the last one is just my approach to plication, which I suspect most of you have done or do routinely. I use a fornix incision most of the time, unless it's an older patient. This is just doing the pull test to confirm we haven't slipped the muscle. Importantly, really clear that anterior tenons. I know Andrea's in the audience, so she's going to say, avoid the arteries when you're placing your suture, which I don't do here. But you put your central cinch knot or central security knot, and then the locking bites, which are really important on either end. And there are different modifications of the plication, which are, have different effects. I'm just showing you the way that I typically do the procedure. Once the edges of the muscle are secured tightly, make sure you've, again, got a nice clear sclera, pretty deep scleral passes, and make sure, at least in my hands, I like to make sure the scleral pass is really close to the insertion of the muscle, otherwise you'll get a greater effect than intended. And here, I had no assistant with me, and I never operate under the scope, but I did it for this video. But I usually put a von Graefe hook under the muscle and replace it so it doesn't stick as it is sticking there. And then again here, just tighten up the sutures, and if you have an assistant, to hold on to that knot if the muscle is wanting to retract posteriorly. Again, if you're using a non-absorbable suture, I would put my sutures posteriorly to avoid that potential for a conj erosion. I always close my tenons and conjunctiva separately. And that's it. Thank you.
So, Ning, I just had one question. Very nice videos. What's your cutoff for the tenotomies? You don't open the conjunctiva, right? You just snip it?
No, I just, so basically, I tend to do most of my surgeries with patients asleep, but if they're awake, you'll grab the muscle, move the eye, or if the patient's awake, ask the patient, are things moving? And then with the tines curved down, I'll just make a snip through conjunctiva and the muscle. And you can see the muscle opening. Of course, you're being careful to avoid those ciliary arteries. If it doesn't look like it was big enough, or if the patient's awake and I'm sitting them up and testing if it's improved, you can go back and enlarge that. Is that your question?
So what's the amount it can correct, generally?
1 to 2 prism diopters. It's really small. If you have more, if you have 4 or 5, if you have a 3 to 4, maybe you could do both, eyes, but it's not going to correct 6 to 8. So then I would go to a central plication or another procedure.
Any other questions?
I was going to ask.
Yeah, I have one quick question for you.
Oh yeah, go ahead.
So, beautiful, wonderful videos, by the way. So, for plication, are you getting the same effect as resection? Because in my hand, for some reason, my plication, I have to do more plication to get the same effect
Yeah, I've
as
heard
resection.
that. For me, I don't do any resections unless, certain situations with complicated re-ops, but I rarely do resections. So for me, in my hands, it's the same. It's the same. I've heard that comment before, and everyone does things a little bit differently. Andrea Molinari has a really nice technique where you put the suit, you can maybe explain it, but it's a little, maybe has a bit more oomph, and so perhaps if you're feeling you're not getting the effect you need, I would recommend trying her technique.
Hand this to Andrea
Sorry to put you on
Molinari.
the spot, but
But
I
I want to ask the audience, how many people, if you're going to strengthen a muscle, do a resection? How many people do a plication? And how many people does it depend how much coffee they've had on the day?
Well, the difference is, you saw when she
You have
places.
to say who you are, where you're from.
Oh, but she already said that.
From Ecuador.
I'm Andrea Molinari from Ecuador, Quito. So the difference, I think there is a difference if when you place a suture, like an adjustable suture on the body of the muscle, and then you pull it forward. It's different if you pull it forward behind the insertion than you pull it forward over the insertion, in front of the insertion. It's at least 1 millimeter difference, and maybe that's why in my hands it's the same effect as I'm doing a resection.
Fabulous. Any questions? Then you
Mic,
have to come
mic,
to the mic. So how many people use, for my plication, how many people use a non-absorbable suture? How many people use an absorbable suture? So I was interested that you were saying that if you're using a so under what circumstances would you use a non-absorbable suture for plication?
I usually don't. For the central plications, when Dr. Wright and I and others are looking at our numbers, there seems to be sometimes a slip over time. So I know he has been switching to non-absorbable, and other colleagues are switching to non-absorbable for everything.
Okay. All right. Go ahead.
I'm Dr. Manjula from Chennai. You were showing the plication. It just forms a bump.
Mm-hmm.
So I think for a larger plication, if you can fold the muscle underneath and plicate it, it's a better technique because you don't see this horrible bump otherwise. Because subconjunctively, if you do larger plications, the bump is very much visible.
Yes,
So
I don't have a problem with that. It flattens out with time, but I know there's
It
other
goes away,
techniques that others have published
The
on.
other thing
It just
is,
adds extra time. But
Jyoti surgery. I think she said.
No, you'll have to wait to the
for it.
end. Okay. Path?
No, I was just going to say exactly about that same comment. You can use, if you don't have an assistant, which sometimes we don't, then it's hard to get someone to use a cyclodialysis spatula to help fold the muscle over nicely. And I think long term, it makes no difference. It looks slightly less bumpy at the beginning, but in the long term, if it folds underneath or on top, it makes no difference to the outcome and the appearance.
it's a good point, though. Depending on your patient population, you definitely have to warn them.
Yes.
And if it's their second surgery, say it's not like a recession. Otherwise, you'll get patients calling you. There's this bump, and you want to just relieve their fears.
Okay, so my question is
Where
like,
are you from?
okay, I'm Dr. Tani from Shillong, India. So how do you titrate the amount of the muscle that you will plicate in case of plication?
So I'm using the same tables that you would have for any tightening procedures. So whatever table you're using for resection, I would just replace that with plication.
Okay.
I'm Dr. Richa from Delhi. So you are doing these techniques for very small, like residual verticals and these kind of cases.
For the central
So
plication?
it-
No, for the tenotomy.
the mini
the
plication or the other central tenotomy and all. So the patient could be having diplopia or not having, it's just a cosmetic concern. A 10-12 PD of vertical would not usually be a cosmetic concern. So you do it in diplopia patients also, like that small vertical is causing diplopia and then you're doing it.
I think I heard your question. So it's purely for diplopia. I mean,
Okay.
you're not doing a tenotomy for
Yes,
cosmetic.
yes.
It's not cosmetically noticeable.
Correct.
Yeah.
Okay.
It's these patients who have a little prism in their glasses and now they're bugged. They've
Yes.
had cataract surgery.
All right.
Okay, so are we gonna move on? Yep.